described.
Yeah, and this is why I love being able to do these. We're very fortunate that people agree to do these PCBH corners because we get to learn a lot from just talking to the experts within the field. And, Jeff, the one thing that you said that stuck out, this idea of, while we might not be married to a name, and I've never thought about this, as we try to start to standardize this more, and everybody knows what a PCP is, like how cool would it be like if everybody knew what a BHC was, right? And there was like some standardization about that. Everybody knew they had core competencies. And Patti, your point, and I just put this in a webinar about if you are a consultant, inherent in that name is you staying up on the research about all these different things that you're consulting on. So it almost like embracing that consultant role, inherently you're saying, we have to stay on top of our game. We have to be the consultant and the one that has the expertise with that. That is just really cool. Now, the one thing I wanted to ask you both, Kirk, within some of our emails, Kirk had mentioned this idea of, one of the things that's really beneficial is, talking about how you introduce what a BHC is and how you go about that. And obviously we have some videos about introductions to PCBH. From your both's opinion, what are the key components of what to say about what a BHC is, and then what are key components to avoid saying what a BHC is?
And not to further complicate it, but what impression do you want to leave upon the patient when you do that introduction? What are you hoping that they, hear on that other end?
Well, I'm hoping they hear something they've never heard before, and that it kind of leaves them with, that's different, or that's new, and that they're really listening at that point in time. So the things that I always teach are for you to say that your job description, so I'm a behavioral health consultant, and whatever your profession is, your license is under, so a psychologist in my case. And then I keep it really simple in terms of describing what I do. I just say I help when people are having problems with living, stress, problems with their health. And then I try to prepare the patient for what to expect in the visit. So I'll say I'll be asking a lot of questions to get a picture of your life as it is right now. Then we'll focus on the problem that most concerns you at this moment in time. We'll put our heads together and try to come up with a plan to make it better. I try to gauge their, or influence their expectations in terms of follow-up. So I typically say something like, a lot of people get what they need in a single visit. And other times people come back to learn new skills, because I'm really wanting them to think of this as, I'm here as a resource to help them live the life they want to live. And then I'll typically note that I'm going to make some notes in the clinical record as we're talking, and that I'll get back with their PCP to let them know the plan.
Yeah.
Yeah, I would say that having been trained by Patti, my introduction looks very similar to hers.
Mine too.
Who would have thought?
Identical.
The one thing though that Patti didn't mention that I do typically describe is I do describe that follow-up structure a little bit more. So the consultant follow-up structure, so I'll say something like, typically patients follow up with me along with their provider until they're starting to improve and they have a clear plan in place for continuing to improve. And then at that point, I usually back out of the planned follow-up and people just continue on with their provider as planned. But I can always be brought back into care, as needed if progress starts slipping backwards or if new problems come up. So I go into that detail around the follow-up structure so that people just, understand that how we do things really. But yeah, mine looks very similar. Otherwise, and then I might, if we bill, I would add that comment in there at the end too. I'd say also we do bill for visits. As far as caveats, I think the biggest one that I see, the biggest problem that comes up sometimes for newer BHCs, or although even for more experienced ones, sometimes I see them doing this too, is kind of discounting their work in this introduction. You know, they'll say something like, now we don't do regular therapy here, right? Or we only do a few visits. Or, you know, I do brief visits, right? So all of these kind of, you know, this adjective brief, you know, or we only do a few visits, it kind of, you know, sounds to me, I mean, if I was a patient, what I would hear with that is, well, what am I getting from you exactly? This sounds like kind of something less than, you know.
Subpar cares.
This sounds like something subpar here. How do I get the real thing, you know? So patients need to feel confident that you're going to be able to help them, that you're in this with them, that you are fully engaged. And when you make these kind of discounting statements, it really undermines patients' confidence, I think, or it would for me if I was a patient. So rather than labeling your service in any way, I just, you know, advise BHCs to just describe it. You know, state that your visits are 30 minutes rather than labeling them as brief, for example. You know, a lot of patients aren't going to understand the difference between a BHC's role and a therapist's role anyway. So, you know, if you try to get too into the, you know, well, I don't do therapy, you know, you're just going to confuse the patient, right? So just, you know, just explaining what you do, leaving it at that kind of.
Patti?
I forgot one thing. I do put in typically as our visit will last about 15 or 20 minutes today. Will that work for you?
And I do add emphasizing really strongly, we're going to come up with a game plan today. You know how you were saying that we're going to put our heads together and come up with a plan. And because at that first time, it's like, what I want them to be thinking as they're sitting there is exactly what Jeff said, is that not that they're getting this subpar thing where it's like, well, yeah, this is cool, but like, where do I get the real thing? I wanted to emphasize that that is the goal. We're going to come up with a plan. Like, you came in here with an issue, we're going to leave here with some direction.
You know, I can still remember Kirk shadowing me, I think, for one of my first appointments at CWFM, and I said in my intro, kind of like, hey, you know, typically we only meet for like 3 to 4 visits, and kind of, again, labeling it as brief. This isn't like therapy. And, you know, Kirk, and like you both said, was like, hey, don't talk about what you're not going to do. You know, talk about what you are going to do. And Jeff, as you said, that confidence that comes along. And then Patti, as you said, like, people might get what they need out of one visit. And we want to empower that almost. We want to suggest that. If we tell people, you know, as we always talk about, like, if we tell people it's going to take you 10 visits to get better, guess what? It might take them 10 visits to get better.
Yeah, that's right. One of the comments I'll get from people when I say a lot of people come for a single visit and get what, you know, they get a plan, they go out, run with it, and things get better. They will spontaneously say, well, I hope that's me.
How cool is that, right?
Yeah.